Everybody, welcome to SEVA VentRounds. Today's January 25th, 2022, and today's called Diaphragm Myoclonus, a scene from the ventilator. I will just make a disclaimer. There's one case, two cases of diaphragm myoclonus, and there's another couple of cases that I thought that it would be interesting also to discuss and talk a little bit. So the disclosures is that we discuss particulars of ventilator modes. No endorsement of any particular mode, manufacturer, or company. We really, as long as it's a ventilator, we're happy with it, and we'll say whatever we say. It's our opinion, and it doesn't represent the Cleveland Clinic. There are my disclosures as well as Rob's Chatburn. The ground rules: just this is a recorded session, so keep your microphone muted, please. I may call upon members of the audience to comment. The best way to comment is to use the chat function, and then if we have a question, we may ask you to unmute and let us know what you're feeling there. And again, for those staff members from the Cleveland Clinic and APPs and whatnot, you can get CMEs. So there's a QR code with a code that you can use at the end of this session to get your CMEs. So I will start. This is not the best picture ever, but it's a picture nonetheless. And just imagine that you're in a room with COVID and you're looking from outside. But this was a post that Angelo Roncalli this is his Twitter handle, put a video which actually showed the patient and then what was happening on the ventilator. And so I thought that I would put this one here, first of all, to recognize his contribution to us. The second, there's another one which is practically the same waveform, which I think that we can do that. But I wanted to give you a chance to read this one, and then we'll move to the other one, as it has practically very similar findings, and there is a bunch of things that we can see on the other one a little bit better. So I would ask, is there any fellow that wants to give it a shot to this waveform? Sorry, to this one.
Mireles, I can give it a try.
All right.
Samit here.
Thank you. All righty. So go ahead.
Very interesting waveform, and correct me that the flow waveform is at the bottom, right? The middle one is the volume, and the top one is the pressure. Is that correct?
You're absolutely correct. So good. That's how you start. Identify where your waveforms are. So contrary to usual standard, which is pressure, flow, and volume, this one is in this way. It doesn't really matter. You can see both.
So, I mean, the only waveform that sort of looks passive is the second wave, where I can see the square shape pressure waveform. So I would call the control variable being pressure. The seems like CMV because this breath is being cycled by the ventilator. So CMV, and then it's set point. So PC-CMVS is the tag. Now coming to load, and I can be absolutely wrong on this one. On the second waveform, it seems like it's elastic, but I can't see the real scale that how many time constants it is, but it seems elastic. Even the expiratory waveform reaches the baseline really quickly, but please correct me if the time scale is changed. But the waveforms after that, there's a sort of this, I don't know, it's like the waveforms are having a seizure or is patient effort, but I would call it inspiratory and expiratory elastic if the patient is passive, but when these activities are happening, I would call it PMUS. So for the second waveform, it's elastic, but otherwise it seems PMUS or whatever it ends up being. In terms of inspiration, the passive waveform doesn't show any work shifting, but I'll come back to the trigger in the end. Inspiration, I think in the PMUS there is work shifting. Cycle, I would say it's cycling normally, but the problem is primarily the trigger, as I could identify it. Expiration also, there's some work shifting, especially in the latter three of the waveforms. I think there's a false trigger. What it appears that either the patient is making some sort of an effort or it's trying to cough or something, and that is being taken by the machine as a trigger. So I would call it false triggering. I mean, I can be wrong. I've never seen anything like this, but it seems as though the patient is trying to make multiple efforts. Is it a circuit issue, or if the patient is coughing? That seems to be the case, but I haven't seen anything like this before.
Thank you, Samid. I think that your read is very good. So we're gonna start. Oh, wonderful! And I see that our fellows are in the room. Ariel also posted and agrees with your tag, pressure control CMBS, and I think that you read it properly. When there's no PMOS, you can clearly see that the pressure is being controlled, and your flow waveform changes with the presence of PMOS. And actually, on the last breath that you can see here, there's essentially no flow under these circumstances. So it tells me, I agree with you that this is a CMV, because you can see that the I time is being controlled because there's this zero flow, which tells you that this is not a spontaneous breath. So I completely agree with you. And you can see up here that it says PCV. I don't know what model ventilator is this one. This is taken as I took a screenshot from the video that Angelo put. And by the way, Angelo could not be with us today, but he sends his regards. So what is the load? I tend to agree with you. I cannot see the time here for each one of the breaths, so it's hard for me to say if it's elastic or resistive, but it has some of the features of being, as you said, elastic, returning to baseline. So I agree with you. And then you see a lot of disturbances that you're reading as PMOS, and perhaps that makes sense, is correct. So I would say that in these three waveforms that you put, in terms of the trigger, this ventilator, at least from what I'm seeing here, there's some keys that tells you if the breath has been patient trigger or not triggered. And at least on this ventilator, I don't see any change on color on any of the waveforms, but I do see the deflections that occur here, dropping the pressure and triggering another breath. And these ones seem to be essentially passive events that were, I don't see any effort on the waveforms from the patient in either or of the two. Así que, so I think that the trigger, at least on these ones, is there. It's just machine trigger, and in these ones, there's evidence of PMOS triggering these two. You can see how it drops. Now, the question here is that true PMOS, as you're pointing out? Is this the circuit, or is it cough, or is something that the patient is doing that is causing oscillations on the circuit? Because there's a lot of oscillations. You can see 1, 2, 3, 4, 5, 6, 7, 8, and then the last one, and then it stops. So there's a series of oscillations from here to here that were not present before. So that goes a little bit against secretions or in the circuit, or fluid in the circuit, that would be triggering this. It seems that the circuit, everything looks beautiful, and then suddenly you start having these aberrancies with positive and negative deflections that affect your flow without a doubt. And you can see that here, how the patient is exhaling, trying to inhale, exhale, then the breath in. So I'm not sure that this falls into necessarily false, but it could be. There could be something that I'm not reading, although we saw there's a video associated with this, which I do. I will retweet it. I have been retweeting it, but it's very interesting to see that. In terms of inspiration, without a doubt, there is some work shifting that occurs here, and we know that there's some work shifting because the tidal volume changed and is and moved up, if anything, and so that tells you that the patient is doing work on top of the breath. But it's not a major issue. It's not your dominant item. And the cycle, I cannot mention anything because there's a lot of noise here. So I think the cycle is normal, as you said, and perhaps some work that is occurring just as during inspiration, as you pointed out. So I'm gonna stop there. I'm gonna put the other waveform, which is actually from one of our patients here at the hospital, and I'll ask if which I think gives you probably nicer picture of what's happening, but you can see the similarities with the other one. And I wonder if anybody wants to read this one too.
I can read this, Dr. Mireles.
Okay, go ahead.
So, in terms of tag, I would say that this is CN, PCCMVS. I'm going to concentrate on the one kind of passive breath or that I can see. That'll help me understand the load and everything else because the first three breaths are purely PMAS. In terms of load, I think the first three breaths are PMAS. The fourth breath, I would say, has signs of just elastic load, but predominantly the load is PMAS. Now for the discordance, so this is so breaking it down systematically, looking at the non-control variable. If we look at the trigger, um, I would say the trigger is normal. The ventilator seems to respond and appropriately. Certainly, there seems a lot of drive. The pressure waveform drops down quite deep, and the ventilator is triggered. So I would say that this is normal. I don't see any early, late, false, or failed triggers. Inspiration, of course, I think that there is work shifting a lot. You can see those dips on the pressure waveform in the middle of a wave, which means that the patient is sucking in, and correspondingly, you see the flow wave, there's little humps in the flow wave, which means that the patient is taking more, causing more in inspiratory airflow. Um, cycle, uh, uh, in terms of cycle, I wonder, I would say, is this early cycle? Because I feel that what might be doing, and in trying to understand the patient's physiology, I was thinking, I mean, at the beginning of the VentRounds, you said something about diaphragmatic myoclonus. But the other thing I was thinking was maybe this is a patient on pressure control and we're trying to bronch the patient. And what's happening is we're increasing the pressure and the patient and the flow is being cut off, but the patient takes a breath and the machine is cycling because of the increased airway pressures because of a foreign body or bronch or something like that. But then the pressure keeps and the patient keeps on taking the breath. So I feel like, is it something like the patient is taking the whole is like is take trying to inhale through the whole three breaths, but the ventilator is cutting off and cycling early because of the increased pressure. But then again, I think an easier explanation could be a diaphragmatic problem. Um, but yeah, I would say that this is an early cycle because clearly I think the ventilator is cutting off the airflow while the patient still requires more air and more airflow. Expiration, I'm not really sure. The between in the expiratory limb after the third breath, you see that the patient is actually actively exhaling. So there is some expiratory work there because there's more deflection downwards. I'm trying to understand the physiology and what's happening with the patient, what to do. Um, I think that my best guess was a bronchoscopy, or once I saw the beginning of your vent round, maybe it's a diaphragmatic myoclonus. Relatively low vent requirements, so I think we're probably in the comfort liberation standpoint strategy. So that's all I have now.
Really great job. Thank you, both you and Samir. Very thoughtful evaluation. So thank you. So again, very well. The tag is exactly the same as the prior one. Pressure control. We're controlling the pressure from the for the breaths. You can see a passive breath. This is a passive breath, and you can see breath meaning passive, that the patient did not do any PMOS. And then this one, which was triggered by the ventilator and actually has other deflections that makes us think that there's a fair amount of PMOS occurring there. So I think in terms of load, this one is all PMOS. And this one over here seems the eye time is short. and then you have this, the return to baseline. Perhaps it just looks normal to probably a very short inspiratory time set here. And they had been working a lot on this patient, so I'm gonna talk a little bit more of how I ended up with this patient and me taking this picture. In terms of the PV discordance, you're right. I mean, every breath is being triggered, and then during inspiration, the patient is doing again efforts. So in terms of PMOS, if I would draw it with a line, evidence of PMOS, there would be evidence of PMOS right here, and then evidence of PMOS right here, at least on the pressure waveform, and then evidence of PMOS right here and right here. And actually right here, you can see the changing flow, changing flow, the changing flow, the changing flow, changing flow. So all of these are manifestations that this patient is having several episodes of PMOS through it. I mean, you can see here how the pressure goes down here, here. So there's 1, 2, 3, 4, 5, 6, 7, 8, 9 evidence of PMOS on this gentleman, which, or patient, it was a male, but it doesn't really matter. The waveform just show a series of positive deflections that tells us that there is inspiratory effort, and then evidence of exhalation, again inspiration, inspiration, a little humpy dumpy here, exhalation, on, in, out. So this is all consistent with that there's something that is moving back and forth on the ventilator. So I actually, how you would call these three breaths, normally in literature, this has been called many ways, from breath stacking, double triggering, I don't know, you can remember a lot of those. And so what we decided in the last taxonomy is just to use multiple triggering, because as this example shows, there you can have more than 2 breaths, not just 2. Yes, in general, what I would say is that once that you get this multiple triggering, the etiology of it, it's very hard to start going by, is the trigger normal, early or late on these patients. So I think that the trigger is definitely normal. It's triggering every single breath when there's a window to trigger. There's some work shifting, as you pointed out, but it never drops the pressure below the baseline. So it's just some. It's not during that period of time. It's evidence of PMOS. The cycle is without a doubt early, and you know that because the machine, actually it's not early, it's late. You actually have here evidence of zero flow and the patient not ventilated, and here actually it looks early. So you can go both, but it's because there's all this evidence of PMOS. So it's really hard to talk about cycle on one of these multiple triggers, Udi. I commiserate with you. And in terms of expiratory work, there's absolutely inspiratory. The patient is trying to do an inspiration here, but I don't see any active expiratory work down in these 2 passive works. So let me ask you to the group, what would you do if you saw this? What are the and I'll give you a little bit of background that will help with your answer. This was a patient in the neuro ICU in which one of our fellows was working there, and it was Chip Welte, who was amazing with the ventilator, and he called me and said, Eduardo, I've been trying for hours to fix this gentleman. I cannot do it. Can you come and take a look? And so I went down, and I tried to help him. This is the first image that I took, and I would ask you to the background of the patient is in the comfort goal, liberation goal, but the patient had sustained a catastrophic brain injury, and they were trying to balance the ventilator so that he would be synchronous and stop alarming. You can see that he would get sometimes very high tidal volumes, sometimes no tidal volume. So they had tried every single mode under the sun. They were having issues from that catastrophic. So knowing now what I have told you, what would you do for this patient, and either for diagnosis or for management, if you may? So I've shown you this and he would do these events consistently. I mean, there were episodes in which he would stop breathing, and then suddenly these several breaths would come in a row. Any suggestions from the team? You can type it or unmute yourself and let me know. Have no fear. I mean, I'll tell you that if it makes you feel better, I had to leave, go read, and then come back. So I see here a couple of comments. There's one from Ariel, says, whatever is causing the trigger, it seems to be forceful as it drops pressure, and also due to air trapping. There's some, I mean, there's no doubt that there's some air trapping during all those inspirations that you can see on the volume curve, yes. So Ariel said, I would try auto mode pressure control. So in these circumstances, it would shift from pressure support to pressure control. So Udi asks, are we sure that these synchronies are actually causing harm? In the overall clinical scenario, in case of catastrophic brain injury, perhaps just let the patient be. Yes, that was one of the issues, but the patient kept having alarms, large tidal volume alarms, then they would go into apnea. So they were trying to move this patient along the spectrum, and that's the rationale, Udi. So let me, so Mohammed wants to change to pressure support and see what the patient does. We actually did that, Mohammed. We tried that, and the same pattern emerged, unbelievably so, that you would see the same thing, and then they would go into apnea for a long period of time. Alarms would start, and then the patient would do this throughout. So we decided, because I couldn't understand what was happening, we checked the whole circuit, we touched the belly of the patient, and you could see the oscillations. And we did a inspiratory pause on expiratory pause. Excellent, Howard. So you also thought about doing an EEG on EMG. So I want to show you just what we did. So this is, you can see the end expiratory pause. And as you know, you can record this on this ventilator. And so what you can see is the heart rate. These were the beats of the heart, those little disturbances. And then suddenly you can see that the patient starts doing effort, and this was PEEP, which was around 8. And then the pressure drops. Actually, I lost it from the screen. There's no way to adjust this that I know of on this recorded screen. So I was trying to capture it. This is the best that I could, but you can see those oscillations that go up and down, up and down, up and down, and then a tonic contraction, and then it would release, and the patient would get that. And this was, we captured this several times, and it was the same frequency that you see on this waveform. So it was these little beeps that you are seeing that are occurring would be exactly the same that were occurring on this patient, which are similar essentially to the case that Angelo shows us, in which there's these active oscillations and movements of the diaphragm. And this is what is called a myoclonic, a diaphragmatic myoclonus, which occurs, the main cause is a brain injury. Encephalitis is the major cause. It has been described now in several events. We did try, so whoever RP said, is the trigger sensitivity too high? And what I can tell you, RP, is that you can see that we actually had switched them to pressure trigger, and it was set, I think, -5 at that time. So, I mean, it was pretty hard for the patient to trigger, because we thought precisely that this was a trigger sensitivity issue. Then the team was trying to block the patient. I mean, we said that's no bueno, so we stopped that. But we were trying to figure out what was the best way to do it. And it was evidently the ventilator was doing what it should have been doing to this myoclonus. This has also been described in the literature with another name. The name is diaphragmatic flutter. And there's another one, which is actually the first description, which was Van Leeuwenhoek described this years ago as a diaphragmatic myoclonus. So in some articles, you'll see it described as as Van Leeuwenhoek's disease. So really cool. And I suspect that we see this probably more often than none in patients with brain injuries, described as very rare, but the eyes don't see what the mind doesn't know. And so I do think that this is at the same time a way for us to recognize that sometimes the diaphragm and the rhythm that comes from the brain. Now, there is another part. There's some of these that are from cortical origin. There's others that are from medullary origin, and some, as recently described, that may be just from diaphragmatic origin. So I presume there's a fair amount of research that can be done when this comes. Now, from what I read, and I'm happy to share the articles that I went through for this, they do EEGs and EMGs. The EMGs, this has been proven by EMG in the past. They have also used diaphragmatic ultrasound, as Mohammed recommended, to try to detect this there. And there is different ways that it has been treated. Some with anti-epileptic medications, some with levetiracetam or phenytoin, clonazepam. And in some cases that have described actually executing the phrenic nerve when it's unilateral in some of the patients, although sometimes it's many of the cases that are described are bilateral. So yeah, this is very, very, very cool and interesting. Thank you, Hara. Any questions, comments from the team? So the summary for this item will be, if you see this type of pattern of aberrancy with a lot of PMOS, you can do an end expiratory to try to figure out what's causing this, if this is false triggering, if this is what type of contraction from the diaphragm that helps us figure that out. And number two, this is associated with brain processes, and the therapy is usually related to anti-epileptics based on the literature that we could see. So there you go. Very good. All right. So I placed a couple of new images, and this is the screen of one of our recently acquired ventilators. So I thought that it would be good for all of us to start getting acquainted with it. And there's a fair amount of good information here. So I would ask, is there any of the fellows interested in reading this one? Anybody? Come on, fellows. Anybody on the fellows room interested on going at it?
I can go, Dr. Mireles.
Who's this?
This is Udi lining up.
Oh, you're gonna double it. All right, Udi. Go at it, my friend.
So I took my time because I cheated a little bit. Sherry actually gave me the conversions of the different tags because but anyway, trying to go back. So trying to see this is the new Hamilton ventilators that we have. So I would say that this is VC-CMV-S, but I confess that I looked at the tag kind of shortcut that Sherry gave me during my service last time. In terms of load, I think that there is basically a lot of PMAS. If you look at the deep kind of depressions during the breath, as you see in the pressure waveform. So I would say nothing except PMAS. Being in a COVID pandemic, looking at the settings from on the right side, I think there is probably some elastic load, thinking of the clinical scenario which we usually see this patient, but I can't see this from the waveform. In terms of discordance, PV discordance trigger, I think the trigger is actually normal. I don't see any early, later falls or failed triggers. Inspiration, there's quite a lot of work shifting. You can see at some points especially in the one, two, three, fourth wave, it almost comes to baseline. So I think this extreme excessive work shifting there. Um, in terms of cycle, I think again it's pretty normal cycle. Um, and in expiration, I think that looking at the curve of I think that there might be some mild expiratory work, but I couldn't be exactly sure. In terms of what to do, seems to be in a pretty safety strategy, extremely high vent requirements. Um, the what I would try to do is in this case is try to attack the pain, anxiety, acidosis, anything like that to see if I can slow the drive down. Clearly, the patient has a lot of respiratory drive and is hungering for air, um, which you are not giving. I think that is the only thing that try to keep the patient safe, try to slow him down with sedation, and try to relieve pain, anxiety, acidosis. I do not think at this time we can liberate him or make him more comfortable, just trying to control the safety aspect.
Thank you, Udi. So I'm going to ask. I think that the Udi, excellent job, and as they are volunteering you, I think uh, down there. Is that are you volunteering or not? I saw your name on the chat, so I don't know if you want me to ask you a couple of questions. Right? Maybe they were joking with you. All right. So there's something that is very cool here, uh, Udi, that actually caught my attention. So the first thing in this ventilator, these little arrows or these little triangles means that it's a patient triggered breath. So you can see that every single one of them has been triggered by the patient. But one of the things that or phrases that I use is that the ventilators are very good at controlling flow and mediocre at controlling pressure. And so when I saw this waveform, and not being used to seeing the this ventilator, I saw the flow waveform. And what do you think about the flow waveform? Does that look like the flow is being controlled?
No, yeah, I don't think it's a completely controlled flow.
It looks like it isn't. But then look at the tidal volume. In the sake of all these PMOS, is the tidal volume changing?
No.
No. So this is one of those in which the answer doesn't, you need to know a little bit more about this ventilator to figure out why the waveform doesn't look like a nice triangle. Ariel says, well, this is because there's different flow shapes. That's true, but this is not because of that. You can see that each waveform actually has a little bit of difference in it, correct? They're not identical, all of them, even though the flow is identical. I'm sorry, the volume is identical. The reason for this is actually quite cool. Is the flow sensor on the Hamilton on this ventilator as it's set up on this patient, the flow sensor is in the Y of the ventilator, which means that when it's not like in the servo in which you're measuring and displaying the flow as it's being measured from the ventilator, so before the circuit. Here it's being measured at the Y just before it goes to the ET tube. So instead of being measured on the ventilator right here, it's measured all the way in the Y right here, which means that as the patient does effort, the circuit has some compliance and some give, and that will affect the amount of volume that goes and flow that generates, and will affect the flow waveform that you're measuring right here. But because the ventilator is controlling the flow, the tidal volume is not going to change. So your flow may look a little bit different. You can see the changes, the major changes in pressure, as you very well identified, with not that much changes on the flow, but there's definitely evidence of some PMOS there. So that's why you see those difference right there, Udi, which may throw you off, but as you start, you read this very well, and that's why we actually created those Rosetta cards that you're reading on the ventilator mode map to be sure that you're understanding what's happening here. Very, very appropriate read of the PMOS throughout the activity. I think when we talk about the trigger, I think all the breaths are triggered except a couple. You see these two here, Udi?
Yeah. Yeah.
And so that those would go with a failed trigger, as Berkan actually recognized. Is in those periods of time, these are failed triggers. These are not early triggers because there's evidence of patient triggers. So the patient triggered, and so any PMOS afterwards would be just part of the first one. So RP, this is volume control. So this is volume control in which the flow waveform doesn't look as it should, because the flow is being measured at the Y, so you get a little bit of the compliance from the circuit measured there. So it's normal for all the breaths, the trigger, and failed for a couple of them. There is work shifting, as you read it very well. The cycle, I think, is normal. And expiratory, there is some expiratory work without a doubt. Now, this was not a COVID patient, Udi. This was a morbidly obese individual in which we were with chronic trach dependence, and we were trying to figure out the best way to set the PEEP chronically, because the patient kept coming back with respiratory distress. So Berkan, I think that you're gonna like this in the next one. So I'm gonna ask one of our. Is there any fellow that wants to jump into this one? The next one is the same patient. I'm just gonna show you an extra feature here that may help you read this better. Any fellow? Come on. You're gonna like this one. Promise. Anybody? Any of our RTs that wants to jump at it? I'm going to show, Hara, I'm going to show a waveform in a second. I want to see if anybody wants to read it. Any of the RTs, any of the fellows? It's the same patient. I'm going to show it now. All right, I'll read it myself. There we go. So this is the same patient. I placed we placed an esophageal balloon on the patient, and now this ventilator allows us to actually display them at the same time, which actually is very useful. So I thought that this would be useful rather than talking about how to set PEEP and whatnot. We could talk about that, but to talk a little bit about the synchrony or desynchrony that we see here. He had received a little bit of sedation, and what you'll see is that you don't see as much work shifting as you saw before. But nonetheless, it shows a fair amount of information. So again, this is volume control, CMV-S, and S stands for set point, meaning that, as you can see here, they set the tidal volume and they set an I time and a rate. And so you essentially set every parameter for this. In terms of the load, it's very similar to before. You see actually during inspiration some evidence of PMOS. And you can see how it's depressing the pressure waveform because this is volume control. You look at the pressure waveform. And this is actually now even more evident now, because over here, so the first channel, you have your airway pressure. The second channel, you have your flow. And in the third channel, you have your esophageal pressure. So this is the catheter that we advanced into a position inside the thorax. And then finally, you have the, if you add so remember the transpulmonary pressure, the transpulmonary pressure is the pressure in minus the pressure out. And that's how it's easy for me, pin minus pout. And pin is the airway, it's inside the alveoli. So if you think about transpulmonary pressure, you have your bronchi and you have your high quality alveoli. And then outside it, you have your pleural space. And I'm just making it exaggerated here for the sake. And so inside this is the airway pressure, which actually measure out here. We don't measure inside the alveoli. And then outside is the pleural pressure, which we are using the esophageal pressure to calculate. So it's the airway pressure minus the pleural pressure, or esophageal pressure in this case, the PES. So you see the airway pressure minus the esophageal pressure gives you the transpulmonary pressure. So the technology here added these two waveforms, and now you have this high quality waveform all the way on the bottom. And so it's this one plus this one. So now that you have that, now we can actually see what's happening to the patient with the PMOS. So essentially, the esophageal pressure is identical to the PMOS. So instead of having to read it as before, we would read it from the waveforms, which actually we can read now. Still, now you have this as like confirmatory, or actually you can read what type of desynchrony you're seeing on each one of these patients. So so let's go down with it. So if I would be reading these without the esophageal pressure, you would start up here, and you look that each one of these breaths has the icon that the ventilator is recognizing that that's a patient-triggered breath, and you have some features that suggest that actually it's this little drop in pressure that you see right there. It helps you, and you see how actually the flow is crossing over and triggering that breath in this given patient. So the trigger seems to be normal. There's no evidence of activation before, and that there's a lot of space or drop in pressure that would tell you otherwise. And I don't see, just like in the other waveform, any failed triggers. Actually, everything looks pretty nice on the pressure waveform and on the flow waveform too. So I would say that this is normal trigger. And if we go down, just for, well, I'll go back to the esophageal pressure in a second. In terms of inspiration, just as Udi had read, there's evidence of work shifting. In this case, it's not as bad as in the prior one, but this is because we gave the patient a little bit of sedation while we were performing some of these items just for comfort. There were some anxiety issues. And then in terms of cycle, what we do see is that there's a drop in pressure from the work shifting, and then there's a little hike here in pressure. There's a pause, and then the patient exhales. So when I read this, I don't see really, I mean, usually if you were thinking that this was a late cycle, you would expect this to climb up, the pressure to move up like that. It's minimally or practically non-existent, if you may. So I would read this as a normal cycle just by looking this. And then during expiration, it seems to be pretty passive. There's some artifacts here that it's actually cardiac oscillations. The patient has pretty intense or large heart, and so we could see in other waveforms the cardiac oscillations. And then, so I would think that the expiration is essentially, it looks normal. It seemed normal to us. So that's how I would have I would read this waveform here. Now that you add the esophageal pressure, so the breath starts here, right here, and I don't have a cursor, but if I or a line to mark it, but if I could, you can see that actually it's pretty aligned. The start of the inspiratory effort and the start of the breath. So using the esophageal pressure, we agree with that. During inspiration, we can see that there's effort occurring, and actually this effort that the patient has, you can see it's not a uniform effort like you would like a beautiful curve. it starts going up, 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 and then there's like a plateau, and then does a little bit more. That may be part of the artifacts from the cardiac oscillations. But you see the effort, and then here is where the breath ends, right here at the tip of the effort. Then it starts relaxing and it goes down. And so in terms of work shifting, there is work shifting. I mean, there's evidence of work by the patient and the formation of the, but it's not at high level of, it's just present. And then in terms of cycle, it seems that it's pretty close. I didn't see a peak here, and I don't see evidence also of early cycle in which I still see PMOS occurring during the expiratory flow. So I would say that in terms of synchrony, this is pretty well matched what we're reading on the waveforms without the need of an esophageal catheter. And then during expiration, this one was kind of cool for us, and we see this, and this has been described in the literature, how the esophageal pressure kind of starts going up during the expiratory phase. You can see that here a little bit better, which it has been identified as activation of the expiratory muscles. And so the patient is actively using some of the muscles, which increases the pressure and starts becoming more positive. And so in this patient in which we were trying to set the PEEP, and you saw we even give them a little bit of sedative, there may be the PEEP was above 0, but when the patient was doing effort and exhaling, it would go below 0, leading to obviously would be negative transpulmonary pressure, which would lead to collapse of the alveoli. So that's what I thought, that this was very interesting from my standpoint of how this device, the esophageal catheter, can help you read the waveforms. But you see here that just by reading the waveforms, you get the same information, well, not the same, but you get some degree of information from the PMOS that you're seeing here, more detailed with a catheter. So I'll see what the questions that you have. So yes, Ariel, there was a little inspiratory pause set at the end of inspiration, which we're still trying to figure out the settings on this ventilator. So there was a small inspiratory pause. Hara asks, so the PMOS is present at expiration as well? Yes, you're right, Hara. So there's a degree of activation of the expiratory muscles that I misread, or I should have read, actually. Thank you for bringing that out. So there's activation of the expiratory muscles. So good point. So here I failed. So I put us, yeah. Which now in retrospect I see it and I said, maybe so. You're right. All righty. Questions from the team?
Hey, Dr. Mireles, it's Russell.
Hey, Russell.
AKA RP in the chat. I'm trying to understand, what was the indication for the esophageal probe? I can't remember what the last one showed, but I don't remember seeing like high peak pressures or a lot of PMUS on the last one. I mean, there was some PMUS that we saw, but was this more for educational purposes, or what was the esophageal probe for in this case?
So the question in this case is was the patient has morbid obesity and chronic mechanical ventilation, and recurrent admissions with hypoxemia. And so the question was, is the PEEP that we're setting for the patient appropriate, yes or no? And so we used then the balloon we said, okay, let's set the PEEP at 0 for this patient, so that he has at least the minimum amount of PEEP and can go and be set there. And so you know how many times we make decisions about, oh, this is he can only go out if his PEEP is below 5 or is below 10, or we can only do this. This is one of those situations in which having more information helps you optimize the care of the patient, so that instead of giving more oxygen, you have the appropriate PEEP, keep him recruited during his activity.
Okay, yeah, thanks for answering that. And so I guess the actual, the driving pressure isn't much at all to get this volume of close to 500. And if you go back to the last one, can you point out the failed trigger there? Which one? Okay.
Do you see the circles I put?
Yeah, yeah. I guess just immediately right after it triggers it, but I guess that one is failed. Okay. I when I was first looking at it from my screen, it looked like the pink the little arrows kind of lined up with it, but I guess it is a little off by a good half a second there.
Yeah, and there's
Okay.
two of
Yeah,
them.
I'm noticing that now.
And that can happen. I mean, that doesn't. Whenever I see this just happening a couple of times, like that the problem is that once that you start reading these waveforms, you're gonna see desynchrony everywhere. You cannot stop. It's just everywhere, and so you have to make a value decision of saying, well, why is this patient having it at this time? What do I need to change? Do I need to change anything? If that if that helps. So in this case, as you can see, the majority of the breaths are triggering as they should. And at that period of time, he had these extra uh, or missed triggers of, as you may call them. So we just didn't do anything about them. And actually, those were the only two that we captured throughout the time that we were at the bedside.
Okay, great. Thanks for pointing those out.
No problem. Any other questions from the team?
Can you hear me, Mireles?
Of course.
Just going back to the other previous ones in the first couple of vent forms, that I've noticed that when patients seem to have a lot of desynchrony, they sometimes they have been switched to pressure trigger.
Yeah.
In this situation, I know that we were actually trying to kind of silence the diaphragm a little bit. But in my understanding, if there's a lot of work shifting and desynchrony, is my conclusion right that it won't help to perhaps add more work to the patient by trying to have a really really high load for the pressure trigger and trying to reduce the desynchronies that way? Would you just comment on that?
Yeah, that's a great question, Uri. I think that the answer to your question is what is the synchrony that or asynchrony that you're seeing, that's what guides my when. Let me flip it a little bit and ask the when is changing the sensitivity to a higher threshold, either pressure or flow. You can do it both ways. When is that indicated? When would you do that? What desynchrony are you trying to deal with?
To my mind, the only time that I actually reduce the sensitivity or do something is or do pressure trigger is in terms of a leak. If there's a big leak
So
and
what's the type of desynchrony that a leak causes?
um false trigger false trigger, right? Yeah.
Yeah. So whenever you see a false trigger, that's when that happens. So I think that that's when I change the sensitivities when I think that there's something else that is triggering that should not be triggering, and then I play with that. And so first you have to make the diagnosis, and after that do it, and after that change it. What does happen is that this is a matter of you do not read, you don't understand what's happening, and they're trying to suppress it by different ways. We're trying to do things to make it go away and look pretty, like the one over here. And as you point out, the only one that I know of that I would be focused on changing the threshold would be if there's false triggering.
Thank you.
Yeah. There's one last question before we say goodbye. Let me just put the sorry. Here's the CME code for all of you, and you just enter this code over here, and that makes you happy and get everything you want. So Ariel is asking, in the volume control CMV graph, something is making that patient breathe fast. Until we figure out what is going on, should we keep it in a mode with a set TI and a preset inspiratory flow, or should we liberate both TI and flow? Well, I think in my mind, it all depends what your goal is. So if your goal is safety, then volume control may make sense. If your goal is comfort, then perhaps letting the patient set up their own tidal volume and eye time makes more sense. So it all depends what we're trying to achieve on a given patient, Ariel. That's how I answer those. Finally, here is the again the CME for the caregivers, and then SEVA webpage. If you guys want to scan that and then send it to whoever you want, so that we get input. So thank you very much. It was a really exciting day to hear your comments. Really good reads from our fellows, Samir and Udi. Really great job. Thank you. Thank you all for commenting and participating. Have a great day. See you in 2